Hello and welcome to the first ILAE Nursing Section webinar for 2025. My name is Melissa and I will be moderating today's session, reflecting on practice during video EEG monitoring, how to respond when bad things happen. Just some housekeeping to get us started. All lines to be muted during the presentations and any questions or technical queries, please put it in the Q&A box. All ILAE Nursing Section webinars are recorded and located on YouTube. You just have to go to YouTube and search ILAE Nursing Section webinars. I'd like to make a special thank you to all of today's presenters for all the work that they've put into gathering these presentations together. The nursing section of the ILAE is a global network of nurses who care for people with epilepsy. The nurses may work in different roles and settings and vary from region to region in economic, social, cultural, racial and ethnic diversity. The nursing section works to promote involvement of nurses from all nations in the care of people with epilepsy and work with the ILAE. Our membership in the ILAE nursing section continues to grow, and I would encourage all those people out there that aren't members, please join us. There's a QR code on this page and a link to be able to sign up for the ILAE nursing section. The objectives of today's webinar: what can be achieved by effective pre-admission review when evaluating patients prior to video EEG, when managing the inpatient environment for those undergoing video EEG, how do nursing interventions impact care outcomes, and how to ensure people are prepared for the potential risk post-admission and what can happen when people go home. Video EEG monitoring is the recording of both video and EEG and is the gold standard investigation for people with refractory seizures and is completed for both adults and children. Although the overall goal of the monitoring is similar, there are differences including length of stay, morbidity and mortality. I started my nursing career in a neuroscience unit that had a video EEG unit, and I remember my first experience of when bad things could go wrong. I encountered a case of SUDEP. I arrived on my morning shift early and I was in the kitchen and the cleaner was there and I could hear the code alarms going off, and I asked, "What bed is that?" And she said, "Oh, bed 47. I was like, "Oh, that can't be right. That's the video EEG patient." And I went straight out there to find out that the person in the bed that I'd looked after the previous days had died. And this was my first real experience with SUDEP and a sentinel event in the unit's history, and it changed practice. The feedback received from the review was that the family never knew this could happen, and moving forward, the discussion about SUDEP occurred with all patients in the monitoring unit, and continuous pulse oximetry and cardiac monitoring was implemented. Having worked in the specialist role for the last 15 years, I experienced the morbidity and mortality related to video EEG. I've been able to reflect and evolve my practice to care for people undergoing video EEG. I now run a hybrid nurse-led pre-admission clinic. Each patient is provided verbal and written information regarding the risks and processes of video EEG. Each patient has written consent completed by the medical staff on admission. Heart and pulse oximetry monitoring was implemented following the SUDEP, and all patients are provided with discharge information to ensure care following discharge. These are some of the interventions implemented to prevent bad things happening in my centre, and I think that the nurse's role is valuable at each stage, and today's presentation will highlight the lessons learned from our speakers. I would like to introduce today's speakers. Our first speaker is Matilda Modigh from Stockholm, Sweden, and she will be talking about paediatric EMU care, navigating the path from pre-admission to post-discharge. And Tina.Yates from Columbus, Ohio in the United States, nursing actions speak louder than words during video EEG. Thank you.
Hi everyone, my name is Matilda Modigh and I am currently working at Astrid Lindgren Children's Hospital in Stockholm, Sweden as an epilepsy clinical nurse specialist with a specialization in pediatrics. For the past 10 years I have been working in the epilepsy monitoring unit where I have gained experience in caring for children with epilepsy. I would like to thank you for the kind invitation to speak today about pediatric EMU care, and I am excited to hear your experiences as well. Understanding the role of long-term video EEG monitoring in pediatric care is key to making accurate diagnosis and creating effective treatment plans. Seizures can look very different from one child to another, which makes diagnosis tricky. This examination helps distinguish epileptic seizures from non-epileptic events, like psychogenic seizures, movement disorders, or behavioral episodes. Long-term video EEG is important because some types of epilepsy have unique EEG patterns that only shows up with extended monitoring, and this examination helps us choose the best treatment for the patient. For some children with refractory epilepsy, surgery might be an option or the only option, and long-term EEG helps locate the seizure focus, giving the information needed for planned surgery. And some seizures happens at night or goes unnoticed, and continuous EEG monitoring gives a full picture of the seizure activity. And we can also use this examination to assess how well anti-seizure medications or other treatments are working by tracking changes in seizure patterns and EEG activity. For certain conditions like tics, sleep disorders, or fainting, they may look like seizures, but they aren't. And long-term video EEG helps tell the difference, preventing unnecessary treatments. By providing a clear understanding of a child's seizures, long-term video EEG plays a critical role in diagnosis and treatments, ultimately improving care and quality of life for the child. The duration of hospital stay can range from a single day to several weeks, depending on the number of seizures that need to be recorded for the analysis. For the majority of patients, the initial seizure is recorded within 48 to 72 hours following admission, but for patients with infrequent seizures, seizure induction methods such as sleep deprivation and anti-seizure medication tempering are often employed. Video EEG takes place in the epilepsy monitoring unit, where continuous EEG monitoring occurs alongside simultaneous video recording, carried out 24/7 in a designated area. And remaining still and staying within a designated area for the duration of the video EEG may pose a challenge for children, as well as sleeping overnight in an unfamiliar environment, and disruptions to the child's usual routine may be difficult. Hospitals can be scary places for children. The unfamiliar sights, sounds, and routines can make them feel anxious, confused, and even threatened. When a child is in the hospital, they are not just dealing with an illness. They are also coping with a world that feels out of their control. Since we know that long-term video EEG takes time, it is important to acknowledge the fact that children may feel restless, scared, or frustrated during their stay. Just think about it from their perspective. They are surrounded by strangers, being poked and prodded with medical equipment, and separated from the comfort of home. Even the language used around them, with words like procedure, test, or monitoring, can sound overwhelming when they don't fully understand what's happening. Therefore, it is important that we know how to make the child feel safe and continually work to improve the pediatric care. A calm, reassuring tone from physicians, nurses, and caregivers goes a long way. Explaining things in simple, child-friendly language helps reduce fear and give them a sense of control. Parents are a child's biggest source of comfort. Whenever it's possible, the parent should stay with the child, hold their hand, and be involved in the care of the child. This makes a huge difference in easing anxiety. Toys, books, and games can be powerful tools as well. Medical play, where kids use dolls or stuffed animals to practice what's happening to them, can help them process their experience in a less intimidating way. But it's also okay for the child to feel scared or upset. Instead of telling them, "Don't worry" or "Be brave," we can validate their emotions, saying things like, "I know this is hard, but you are doing such a great job," helps them feel understood and supported. When children feel safe and comforted in the hospital, they cope better and build trust with the healthcare providers. By taking small steps to reduce fear, we can make a big difference in their experience and help them feel truly safe during the hospital stay. A hospital stay for long-term video EEG monitoring can feel overwhelming for both the child and their family. The unfamiliar environment, medical procedures, and extended stay can create anxiety. However, with proper preparation, we can help ease their concerns and make the experience more comfortable. Using image support and visual aid can make a big difference in helping children understand what to expect. Providing pictures or illustrated guides can show what the hospital room will look like, how the EEG electrodes are placed on their head, what activities they can do during their stay. In Sweden, we have a website called MediPrep, designed for children to help them prepare for hospital visits so they can feel safe. For example, we have created a child-friendly video that explains EEG monitoring in a way that it is easy to understand. Families can watch this video together to help children visualize what will happen when they come to the hospital. So what can we do to ensure that the stay is safe? Well, first of all, talk to the family. Explain the procedure in simple, reassuring terms. Make sure they understand why the video EEG is needed and what it involves. Let them know that it is a safe and effective tool for monitoring seizure activity, but also allow them to ask any questions they might have. For children, it is important to explain things in a way that it is sensitive to their age and emotional needs. It's also crucial to gather detailed information about the patient's medical history. So ask if the child has had any injuries or seizure-related emergencies in the past. This could include previous hospitalizations, severe seizures, or other medical events that might affect the child's care. Understanding this history helps us anticipate any risks and manage the procedure more effectively. Understanding how the patient responds to changes in medication is another key factor. Ask the family about the patient's current medication regime and if there have been any recent changes. This information helps us assess potential side effects and adjust our approach accordingly. Additionally, inquiry about how the patient typically responds to rescue medication, because knowing how they react to these medications ensures we are prepared for any emergent situation during the stay. Some children may feel more comfortable than others, but all children can benefit from reassurance and support. If the child is feeling anxious about being in a medical setting, talk to them about what they can expect. Reassure them that our team will be there every step of the way, guiding them through the process with care. Ask the patient and their family what they need to feel safe during this examination. Encourage the patient to bring along someone they can trust, like a parent or sibling or a close family member. Having a familiar face in the room can provide immense comfort and reassurance. The patient will be more likely to feel safe and supported throughout the procedure if they have someone by their side who they feel comfortable with. Personal belongings can also provide a sense of familiarity and security. Encourage the child to bring items they can feel safe with, such as a favorite toy or a book or something else from their home. These small but significant items can provide comfort and create a sense of normalcy during their time in the hospital. For patients who come for long-term video EEG monitoring as part of the epilepsy surgical evaluation, we have long noted that their hospital stays were long, just as the literature says, but also that it didn't always help, no matter what we did during their stay. This patient still did not have any seizures. Some patients then had to go home without registered seizures and instead had seizures as soon as they went into the elevator on their way home from the hospital or when they arrived home. Therefore, to try to avoid long hospital stays without seizures as well as readmissions, we have established guidelines for how we should manage, especially the patients who come for long-term video EEG as part of their epilepsy surgical evaluation. Now I call all patients about a week before their admission, identifying their current seizure situation, how things have been recently, the semiology of the seizures, whether it has changed, and if the families have identified factors that can trigger seizures. If the seizure frequency is low, but it is still justified to perform the examination, we start a slow medication tampering at home. We feel comfortable doing that if the patient has no previous history of status epilepticus and as long as the parent feels comfortable with doing it. If the family has identified factors that can trigger seizures, such as physical activity or stress, I contact a physiotherapist, hospital, school, and play therapy to help activate the patient during the stay. All of this is documented in the medical chart so the physicians and nurses in the ward can read it when the patient is admitted. Every day we have a daily round with the neurologist and the nurse and staff from the neurophysiology department to review the EEG, seizures, and semiology. During the daily round, we discuss ongoing recordings, whether provocative methods need to be added to induce seizures, and if we are satisfied once we have recorded seizures. If we are satisfied with the recordings, the neurologist and nurse usually inform the families briefly about the preliminary results. We also explain how long it will take to get the final results and how the findings will be communicated, whether it will be by phone or in person. If it's possible, we try to schedule a follow-up appointment so they have the appointment before they go home. We provide information about any medication adjustments made during the hospital stay and which medications the patient should continue with. For the patient who is ready to go home, medications are reintroduced and sometimes we give a first loading dose to quickly reach the necessary blood concentration. We also ensure that the patient and family know which medications and which doses the patient should continue with when they return home. All of this is done to ensure that it feels safe and secure for the patient to leave the hospital. So, to summarize, long-term video EEG monitoring is a crucial step in diagnosing and managing epilepsy in children. Through this monitoring, physicians and nurses can assess seizure activity, evaluate treatment efficacy, and determine if the patient could go for surgery. While hospitalization may be challenging for a child, proper preparation and support can help alleviate fear. Ensuring that the child and family are well prepared is key to making the process as safe and comfortable as possible. Thank you for listening.
Hi everyone! I would first like to thank the International League Against Epilepsy Nursing section for allowing me to speak on a topic near and dear to my heart. My name is Tina.Yates, Advanced Practice Registered Nurse with my doctorate degree. I work in the United States in Columbus, Ohio at Ohio Health, a Level 4 Comprehensive Epilepsy Center. I practice in the Epilepsy Monitoring Unit, EMU, and Epilepsy Clinic, specializing in sudden unexpected death in epilepsy, SUDEP prevention, and seizure safety in the EMU. We are going to examine how nursing actions speak louder than words during video EEG. I was asked to explore how nursing interventions actions impact patient care outcomes during video EEG. Today's discussion will focus on determining the why, where, when, who, what, and how of seizure response. We will talk through ways to achieve efficiency and accuracy of seizure response in SUDEP prevention and seizure emergencies. We will examine a seizure response action plan for seizure responders during video EEG and identify nursing responsibilities during seizure response. This slide signifies why this topic is near and dear to my heart. In 2019, I was at a pharmaceutical dinner with an epileptologist from a well-renowned Level 4 Comprehensive Epilepsy Center discussing various seizure rescue medications. Following his talk, we were discussing the responsibilities of the advanced practice nurse at his facility. He suddenly lowered his head with a disappointed look on his face, and he said, "We had 2 SUDEP cases in 1 month in our EMU, and the team recently had to revamp the EMU from the ground up." As he talked, I thought, what is our organization doing to prevent SUDEP? In our EMU, we are fortunate enough to have no SUDEP cases, but we know of several near SUDEP cases. I knew then I wanted to go to school for my DNP degree, and my DNP project will focus on SUDEP prevention. During the doctorate degree program, my focus expanded to seizure safety in the Epilepsy Monitoring Unit, inspired by several epileptologists. We completed a 3-month retrospective organizational assessment looking at various seizure indicators with the inclusion criteria of focal seizures with secondary generalization. We determined the seizure indicators from our epilepsy experts and organizations such as the American Academy of Neurology, International League Against Epilepsy, and the National Association of Epilepsy Centers. We concluded practice gaps in all seizure indicators. The findings were presented at the American Epilepsy Society's annual meeting in 2022. See the poster on the bottom left of your screen. The Moderator study by Rivalin and colleagues at the top of your screen was a systematic international retrospective study looking at cardiac arrests, SUDEP, near SUDEP, and other causes of death in the EMU. The Moderator study paved the way for highly informative SUDEP data and signified my passion for SUDEP prevention and seizure safety. The Moderator study determined concerns for non-adherence and incompetence of nursing staff. Post my doctorate degree, the second phase of the project continued and focused on implementing quality improvement initiatives from 2022 and is ongoing. Essentially revamped our EMU from the ground up. We did complete a post-retrospective organizational assessment and found improvements in most seizure indicators. We presented our findings at the American Epilepsy Society's annual meeting in 2024. See the poster on the bottom right of your screen. One of the quality improvement initiatives was the development of the Seizure Response Action Plan. The development of the Seizure Response Action Plan was tailored from the use of seizure action plans, which are personalized guides on what, when, where, why, and how patients, caregivers, and others will interact with the person having a seizure. The Seizure Response Action Plan will focus on the responsibilities of seizure responders by exploring the who, when, where, why, what, and how in managing seizure response and responding to seizure emergencies. While specific policies and procedures for EMUs lack universal guidelines, they should be developed based on international and organizations' recommendations, expert opinions, and customized based on resources available within your EMU. The Seizure Response Action Plan was developed with a focus around responding to seizure response, as if you are responding to a code blue with precision, efficiency, and effectiveness. Ultimately, we determined less individuals in the EMU room is essential. The who for seizure response will include a primary RN, charge RN, EEG technician, and nursing assistant. Let's now discuss the what to do during a seizure response and how to do it. The EEG tech notifies responders the patient is having a seizure. The EEG tech and/or primary RN will check patient to determine what stage of the seizure the patient is experiencing, a focal seizure, tonic-clonic seizure, or is the patient in a postictal state. The EEG tech will state what seizure stage the patient is likely experiencing and provide guidance on seizure response steps. The nursing assistant, charge RN, or EEG tech will turn on the lights, whoever arrives first, and remove the bed blankets off the patient for camera view. If a focal seizure, the primary RN will use the seizure assessment cards, which are specific seizure semiology tasks, to assist the epileptologist in determining the seizure onset zone. The primary RN will call out their assessment findings. The primary RN is on the right side of the patient's bed to ensure camera view of the patient. The EEG tech is in the room monitoring the EEG tracings, verbalizing what stage of the seizure, verbalizing seizure response steps, and documenting seizure response findings. The charge RN is on standby if the focal seizure would progress. The nursing assistant is on the left side of the bed and will pull the blankets off of the patient if not already done, put bed in lowest position, side rails up ×4, and remove the patient's mask if needed while calling out their findings. The nursing assistant will assist patient to a safe position if needed, lay patient down, and protect head. The nursing assistant will stay on the left side of the patient to be ready if the focal seizure would progress. The nursing assistant will check and make sure suction is working if time permits. What to do if the focal seizure progresses to tonic-clonic seizure or the patient is in a tonic-clonic seizure? The primary RN is on the right side of the patient's bed and will assist the nursing assistant, who is on the left side, to turn patient on the right side, facing the nurse for camera view. If patient is in an unsafe position, like a side chair, bathroom, the responders will use discretion with need to turn the patient on their side. The charge RN will turn on the light and pull the blankets off of the patient if not already done. If patient is sitting in bed, the charge RN or nursing assistant will put the bed in the lowest position, side rails up ×4, and remove the patient's mask if needed, and will call out their findings. The charge RN will assist with turning patient, suctioning, and oxygen if needed. The nursing assistant or charge RN will hand the primary RN suction and oxygen. The primary RN will suction, place oxygen at the initial onset of the tonic-clonic seizure, and monitor the telemetry rhythm, heart rate, and oxygen saturation. The primary RN will also be assessing for eye deviation, eye version, head version, and figure 4 and call out their findings. If tonic-clonic seizure, the charge RN will contact the EMU epileptologist. If the seizure lasts longer than 3 minutes, the charge RN will contact the EMU epileptologist to discuss a need for a benzodiazepine administration. EEG tech is still monitoring the EEG tracings, verbalizing seizure stage, verbalizing seizure response steps if needed, and documenting their findings. What to do if abnormal telemetry rhythm? The primary RN or charge RN, if any abnormal rhythm or sinus tach, they will check the patient, check pulse. If asymptomatic sinus tach, notify the EMU epileptologist. If bradycardia, observe and check patient. If heart rate less than 40 or they identify the heart rate is dropping, the charge RN will call the rapid response team. If asymptomatic bradycardia, they will notify the epileptologist. If asystole, a pause or pauses, AV block, ventricular fibrillation, ventricular tachycardia, atrial fibrillation, they'll check the patient. If no pulse, start CPR, call Code Blue, and follow the Code Blue guidelines. They will document findings and notify the EMU epileptologist if not already done. What to do if low oxygen saturation? The primary RN or charge RN will increase the oxygen as needed to no more than 6 liters nasal cannula. Continue to have patient on their side or turn on their side. Suction as needed, and if no improvement in oxygen saturation, place non-rebreather, and call the rapid response team. They also will need to notify the EMU epileptologist. What to do when the generalized tonic-clonic seizure stops? Patient now in the postictal stage. Primary RN will continue with patient lying on their right side, suctioning and providing oxygen as needed. The primary RN will continue to assess until patient is responding, which can last up to or longer than 15 minutes. During the end of the seizure and during the postictal stage, the patient is at increased risk for SUDEP, with experts hypothesizing cause of SUDEP can include cardiac arrhythmias, respiratory compromise, and cerebral shutdown. Other concerns during the postictal stage can include aspiration pneumonia, injuries, postictal psychosis, and status epilepticus. The nursing assistant will obtain vital signs at this time: blood pressure, heart rate, and oxygen saturation. No need for glucose test unless the EMU epileptologist or advanced practice registered nurse orders. The nursing assistant will call out their vital sign findings. What to do if postictal aggression, agitation, restlessness. Seizure responders are to stay calm, limit overstimulation of patient, defer any vital signs assessments unless absolutely necessary. Do not attempt to hold the patient down, refer to the postictal protocol, give patient space, limit the number of people in the room as able, but have available resources and assistance nearby. If the patient has a cluster of seizures or seizures last longer than 5 minutes despite benzodiazepine, what to do? The primary RN and/or charge RN will refer to the status epilepticus protocol, and they'll notify the EMU epileptologist of their findings. Now that you have heard the responsibilities of the nursing responders during seizure response, do you think nursing actions speak louder than words? I do think our nursing actions speak louder than words, but we need the words, the knowledge to take action. Thank you.